Okay, I'd like to introduce Dr. Stipica Mudrazija. He's an assistant professor at UW School of Public Health. His research interests include financial gerontology and intergenerational transfers, disability and caregiving, dementia, health disparities among older adults, health and welfare policies, and cross-national comparative study of these topics. So you can see he has a broad-based expertise in racial and ethnic disparities in prevalence and economic impacts of dementia. Welcome, Dr. Mudrazija.
Thank you. And first, this topic really is it's taking a macro view, but I do hope that even those of you who may not normally be focused on macro picture will find at least some aspects of this interesting and relevant to what you are doing. So let me give you just a little bit of an overview of today's lecture. First, I'm going to talk about prevalence of ADRD, so Alzheimer's disease and related dementias. And I apologize in advance for using a lot of acronyms. I'll try to spell them out fully the first time we encounter them. And so first, I'm going to talk about, as I said, Alzheimer's disease and related dementias prevalence and differences by race and ethnicity. Then we're going to move ahead talking about current and future economic impacts of ADRD for care recipients, for caregivers, and for others. And finally, there's going to be a brief discussion of the implications of the findings. So when it comes to the prevalence of dementia, it actually is somewhat surprisingly difficult to put the exact number on the paper. So we know that there's a large number, approximately 7 million Americans who are living with dementia. And overwhelmingly, people with dementia are white because most of the older adult population is still white. Yet there is a strong empirical evidence that shows that minoritized populations, including especially African Americans and Latino older adults, have higher rates of cognitive impairment. As far as other racial and ethnic minorities, the picture is a little bit more complex. There is some evidence, some studies find that American Indian and Alaska Native populations have higher rates of Alzheimer's disease and other dementias relative to white population, but the findings are not consistent across all studies. Whereas for Asians and Pacific Islanders, most studies find similar or sometimes higher, and in a few more cases, probably lower rates than for whites. The actual magnitude of these differences is still somewhat unclear, which may come as a surprise. But the reason is that there are differences between survey estimates and also clinical assessments. So based on surveys estimates, arguably the most often cited number is that African American older adults are approximately twice as likely, and Latino older adults approximately 1.5 times as likely as white older adults to have ADRD. That, I believe, is based on using data from the Health and Retirement Study, and more specifically ADAMS, which is a gold standard for survey estimates of ADRD prevalence, and is focused on population ages 70 and older. Some other sources, however, put a Latino number higher. close to or even higher than for African Americans, but those studies are in minority. Now, one of the issues that can arise with survey algorithms, because as I said, these are not clinical assessments, these are survey algorithms that basically classify people based on certain characteristics, answers to certain questions, whether they're above or below certain threshold, and then basically assign them as likely having ADRD. So the problem is that survey algorithms have been found to potentially overestimate prevalence for minoritized populations. But there have been also efforts to ameliorate this and to account for this bias. So, for example, that same study that I mentioned, health and retirement study, now has user-contributed a segment where they produce race ethnicity specific algorithmic assessments of Alzheimer's disease and related dementia's prevalence. When it comes to diagnosis, the data suggests that African American older adults are only about 1/3, and Latino older adults about 20% more likely to be diagnosed with ADRD compared to white older adults. So you see this discrepancy between survey estimates, where I mentioned most often cited number twice as likely, 1.5 times as likely. Whereas here we are talking about only about 1/3 as high or 20% as high. So what can account for this difference? Well, there is a substantial underdiagnosis. And in fact, there is a systemic undercount of dementia based on diagnosis alone for minoritized populations. Therefore, diagnosis for African Americans and Latinos disproportionately happens at an advanced stage of disease progression. So as you can see, each of these two different strands of data that we have on the prevalence of ADRD has some advantages and some disadvantages. So what explains differences in prevalence more generally? At the population level, we can roughly divide causes of Alzheimer's disease into genetic factors and then exposome, which exposome is basically the totality of environmental influences, including modifiable risk factors. And in fact, there's been some years ago now, a prominent study that was published in Lancet that claimed that about 40% of dementia cases could be prevented or delayed by addressing modifiable risk factors and social determinants of health more broadly. So, other studies show that when we compare across racial and ethnic groups, there is really no strong evidence for any kind of systemic differences in the prevalence of dementia that would be attributable to genetic factors. And so this already suggests then that the differences that we observe across different racial and ethnic groups primarily stem from other factors, especially as it relates to social determinants of health. So basically, the differences are really focused on those 40% of modifiable risk factors, the racial and ethnic differences, rather than the 60 or so percent of what is essentially considered a genetic cause of the disease. So that's, about the prevalence of Alzheimer's disease. Now, what is an important factor and something that is really the central focus of my own research when it comes to dementia is the economic impacts of dementia, the economic impacts of ADRD. So, as you will all be aware, Alzheimer's disease and related dementias do have substantial economic implications for older adults who suffer from it, for their family members, but also for the society more broadly. And these economic impacts range from direct cost of medical treatment to the cost of paid institutional and home care, the value of unpaid informal care, care that is primarily provided by family members, to foregone earnings for both adults with ADRD, especially those who have early onset and may in fact have the onset before they would normally leave the labor force, but primarily for their unpaid caregivers, their adult children who need to take care of their parents and therefore either fully leave the labor market or scale back the number of hours of work that they can do. There are also other impacts that often are not regarded as much, but I'll try to show to you some of these other impacts that are related to lost income tax payments, among others. And, when we think about economic impacts of Alzheimer's disease, the fact that Latinos and African Americans have a higher prevalence of ADRD than whites translates ultimately to a higher reliance on family supports, and therefore both African Americans and Latino communities suffer more economically from Alzheimer's disease. What makes this issue particularly pertinent is the fact that the number of older adults is growing. The number of people living with dementia is growing very fast. And so over the coming decades, driven primarily by changing demographics and population aging, there's going to be an explosion in economic impacts, adverse economic impacts of dementia. Just so you get some sense of it, the number of people with dementia will approximately double, and the old age support ratio, so that's basically the number of people who are of working age relative to number of people who are of retirement age, will almost halve by 2060. In other words, there are going to be many more people needing support, and relatively speaking, fewer people to provide it. What makes it particularly important for minoritized population is that not only that we are becoming majority minority nation as a whole, but we are slowly getting there also among older adults, which, as I said, is still predominantly non-Latino white, but increasingly is becoming dominated by minoritized populations. So I will not really bother you all that much with data and methods. This is here more for your reference. So once you get the handouts, once you get hold of slides, you can see all various data sources that fed into making these assessments, these projections. But suffice to say is that one needs to take into account many different data sets and many different sources of information to try to approximate costs for so many different elements and for so many different players. So let me now talk about the results. First, I'm going to talk about care recipients. Here, I'll first present what the medical care costs are currently. And when I say currently, I refer to 2020, so just as of a few years ago. And then we'll talk about the estimates for the coming decades. And so first thing, and I just want to also make one note here. Because of the conventions of how things are reported in health economics, my colleagues and I decided that we are going to apply an assumption of 3% increase in medical care costs, and in all costs that we are taking here into account over this time frame. What this means is that the numbers that you see are not numbers that are directly comparable over time. So they are nominal numbers. They are not real numbers. And what that really means is that if one would want to see how much the cost in 2060 is worth in 2020 dollars, then one would have to make a little bit of an adjustment. Just as a rule of thumb, if you divide the amounts that you see in 2060 by 3, you will get a number that is comparable to the number in 2020 in terms of the dollars. It's almost like, taking away the impact of health inflation over this 40-year period. So just as an example, if you, for example, look at medical care costs for older whites, in 2020, they were estimated to be about $16 billion annually. And by 2060, they're going to grow to $90 billion in nominal terms, or if you divide that number by 3, that would be about $30 billion in 2020 dollars. So you can say that the number is going to grow about 6 times from the level that we had in 2020 in nominal terms, or that it's going to double in real terms between 2020 and 2060. So that's sort of just to give you a sense of how you could interpret these results. And again, we did this because of the conventions in the discipline, but fully aware that in some instances, a different way of showing the results may arguably be more intuitive. So we see that in 2020, the total costs, medical care costs, are basically around $20 billion across African Americans, Latinos, and whites. And overwhelmingly, they refer to whites by a factor of 4 to 1, 5 to 1. By 2060, we see that there's going to be a huge increase in costs, both in terms of nominal or real costs. No matter how you look at it, the costs are going to grow pretty dramatically. But as you can see, much more so for non-white populations. You see, for Latinos, the growth from 1.8 to 32 billion. There we are talking about the factor of at least 15 times or 5 times in real terms. For African Americans, similar, just slightly less so. Whereas, as I previously talked about whites, that pace of increase is going to be sharp, but not nearly as sharp. When it comes to work-related losses, so this basically refers to people who are at an age where they might still be working, but because of the early onset of dementia, they have to stop working before they would normally retire. As of now, these losses are about $4 billion annually. Those losses are going to increase quite sharply as well. So overall, across both white population and two major minoritized populations, we will have an increase in cost for care recipients from 24 to $169 billion. Furthermore, the part of the cost for care recipients that is even larger is for their formal care institutions, as well as home care. So here I'm focusing on paid home care and nursing home care. And here you see again the same pattern of the explosion in costs that overall are going to go from up from about $83 billion, which is what it costs us today, to 600 and almost $80 billion in 2060. Or, as I said, if we divide that number by 3, that would come to be to about $230 billion. In other words, even in real terms, we are going to talk about tripling in terms of the cost of paid home care and nursing home care. Most of that cost refers to nursing home care, although the faster pace of growth is actually for paid home care. And this is partly related with the labor market and the fact that we have a lack of labor force to staff paid home care. But another thing that is very important has been in recent decades, policy efforts to divert people from institutionalized care into community. And so some people that in the past would have been would have transitioned to a nursing home will be staying longer in the community, and therefore there's going to be some redistribution from some expected redistribution from institutionalized care toward paid home care. Now, when it comes to caregivers, this is, first of all, I want to say that this is the biggest slice of the cost. So everything, all the numbers that you've seen for care recipients, no matter how large they are, they actually still pale in comparison compared to the numbers that you're going to see for caregivers. And before I start talking about the costs, I just want to give you a sense of the number of people providing care and the expected number of people providing family care in the future. And this comes from a different, related but different study, and therefore it's not broken down onto African Americans and Latinos, but it just has the this dichotomous division on whites and non-whites. But for the most part, non-whites here do refer to African Americans and Latinos, just combined. So as it relates to dementia, currently we have about 6 million people, almost 6 million people providing family members providing care to persons with dementia. And there are about 12 million, almost 12 million people providing family care to family members without dementia. So it's about 2-to-1 ratio. And these numbers are going to increase quite substantially over time, so that by 2060, we are going to have also almost twice as many family caregivers of white people, white older adults with dementia, and more than 5 times as many family caregivers of older adults, non-white older adults with dementia. And there's going to be similar increase in terms of the numbers and proportions of caregivers, family caregivers to whites and non-whites without dementia. So overall, the number of caregivers in the United States is going to grow from about 17 to 18 million right now to over 47 million by 2060. And when making these assessments, I just want to also use the opportunity to say that as much as there is uncertainty about the numbers when it comes to the prevalence of Alzheimer's disease, you wouldn't believe how much uncertainty actually there is about the number of caregivers in the United States. And this is due to the fact that there is no one universally accepted definition of who counts as a caregiver. And so depending on whether caregiving is limited just to certain types of help, and whether the help needs to be directly health related, as it is, for people that I'm counting here, or it also includes any type of help. So, for example, you have an older parent, and you just help your parent with doing groceries, or you drive your parent around, but the help itself is not necessarily motivated by any kind of help need by the parent. This wouldn't count that kind of help as health-related caregiving, although in some definitions that very same type of help may count as long as it is justified in the survey as motivated by health needs of the parent. So this gets very tricky, and that's why you're going to see estimates vary from just 4, 5, 6 million at the lower end to 50 million Americans providing care already today. And so, this is the estimates can vary by a factor of 10. But the most commonly used, the most reliable estimates are the ones that I'm presenting to you, and they're in fact based on the National Study of Caregiving, a supplement to the National Health and Aging Trend Study, and that is arguably considered gold standard these days in terms of learning about caregivers, not only their numbers but also their characteristics. So there are two main elements when it comes to the costs or the value for caregivers, and this is something that I refer to it as the value of caregiving and cost of foregone earnings. Now, those that are trained as economists could also find appealing to make this into a distinction between replacement costs and opportunity costs. So replacement cost, as the name says, is the how much money you would need to replace family care with professional care. Opportunity cost is basically the cost of the alternative use of time, right? So what could have you done with the time that you spent caring for an older parent, let's say? So first, these replacement costs, or in effect, the value of caregiving, a value of unpaid care for older adults, it is significant, and it's just gonna go up in value. I mean, as of now, we can say that family caregivers, unpaid family caregivers, provide care that, even if valued at the national minimum wage, is still at about over about $73 billion worth annually. If we actually apply the replacement wage, so the wage that the professional would command, this grows at least by a factor of 2. So we are already talking about 140-50 billion dollars, and for African Americans and Latinos, it's almost half of that number. Now, what is going to happen by 2060, as with everything else, is that these numbers are going to grow dramatically. In fact, in particular for African Americans, by almost 10 times, and for Latinos by about 15 times. So about similar as what we've seen for care recipients, but just here on caregivers' side. Overall, in 2060, if we were to replace caregiving that is provided by family members with professional caregiving, that would cost us in 2060 dollars about $1 trillion, 1 trillion with a T. Or about 300 and some billion dollars in today's money. Now, the other side of the coin. So in some sense, you can think of the replacement costs as almost like a free lunch for the society, right? It's almost like this is something that the government doesn't have to spend on because it is provided by family. But there is the other side of the coin, and that is that caregivers who provide unpaid care, beside the fact that they suffer a lot of burdens when as it comes to their own health and emotional burdens and all the things that come with care, caring for older parent with dementia. There is also an important economic cost of foregone earnings, because many of the caregivers, not all of them, but many of the caregivers would have worked in the absence of their caregiving responsibilities, and many, even more so, would have worked more. So they had to scale back their hours of work. And so when you start looking at those numbers, there is one important finding, and that is that while as of now the replacement costs are still larger than the costs of foregone earnings, as we move toward 2060, as we go toward the future, the costs of foregone earnings are going to be catching up with the costs with replacement costs. In other words, the money that caregivers are losing by not participating in the labor market, by being effectively forced to be excluded from the labor market, is going to start catching up in value and even surpassing in value the implicit value of that care that they are providing, which raises important issues in terms of how much support the government should be providing to support caregivers and their participation in the labor market. And we'll come to that when we get to the discussion. But right now, I still want to present you a few numbers. So this is when this is just a figure that illustrates how faster the growth in foregone earnings is for, in particular, Latino caregivers. Those are the white bars. Then for white caregivers, those are the brown bars. And then there's an increase for African American caregivers, but at a slower pace than for Latino caregivers. Now, these are all numbers these are all total numbers. What is also important to see, and I apologize if there's a background noise. I have to say I got my cat here, so she is just making some noise. What is important to see is also how this impacts individuals, not only to look at the macro aspect of this. And so when we look at individuals, we can see that per person amount of foregone earnings is going to grow pretty radically over the next 4 decades across all groups, but especially for Latino caregivers. And in fact, Latino caregivers, even though they have lower socioeconomic status, they, in fact, even today, experience higher foregone earnings than non-Latino white caregivers. And this is going to change dramatically in the coming decades. What is particularly interesting here, though, is how things are going to change in terms of the household income. And so while right now an average white caregiver loses about 8% of their income, so that's the value of foregone earnings. The number stands at about 9.5% for African Americans and full 16% for Latino caregivers. And this is clearly related to the fact that Latino older adults overwhelmingly rely on their family members for caregiving. There's a historical, cultural component to it, but also there's a structural component to it, and including, the lack of formal care and professional care, be it paid home care, be it institutional care, that is, adjusted for Latino population as it relates to language or other considerations. And so over the coming decades, the percentage loss or the foregone earnings expressed as percentage of household income is going to grow across all groups, but more so for minoritized populations than for whites. and in particular for African Americans. Beyond foregone earnings, there is also an element of financial transfers. Now, while most of family caregivers focus on providing hands-on care to their parents, many still incur financial costs related to their parents' care. And so even today, there's about $11 billion annually spent by family caregivers for older adults with dementia, above and beyond the hands-on care that they are providing. And as with everything else, these numbers are going to go up as the population ages and as there are more and more older adults with dementia to take care of. Here, finally, there's also this, one could almost think about secondary effects, because there are these primary effects, and there is how much economically dementia impacts older adults who suffer from it, and how much it impacts their family members. And those are they make up the bulk of the economic impacts, but that's not everything. So employers of caregivers who take care of older adults with dementia actually experience some losses themselves. And this is something that economists call presenteeism and absenteeism. Those are the elements that constitute labor productivity, or the loss of labor productivity. So essentially, absenteeism is the situation where people who are working have to take time off unplanned because of emergencies related to the care for their loved ones. And presenteeism refers to lower productivity because during nominal work hours, one may need to take care of some parent-related emergencies. So, for example, filling a prescription or calling a doctor and scheduling an exam. And so, to the extent that these things are done during work hours, that may decrease the productivity. And so, when you take into account those estimates of losses for those who are working, who are able to continue working while providing care, that accounts for about 16 or so $billion today, and will grow dramatically in the future, and will grow for two reasons. One, as we've seen, there's an increase in population of older adults, increase in the number of caregivers. They're going to be exposed to this loss of labor productivity. However, there's an element that I haven't emphasized previously, but that it also is important here, and that's the educational level. So as the population, so first, the US population is getting better and better educated over the years, and there is really no clear indication that people are gonna stop increasing their educational level. I mean, if anything, the experience from the last 4 decades has been that there's been, if anything, an acceleration in terms of the college degree attainment in the United States, and there's still enough room for the college degree attainment to increase in the future. Now, the implications of that, when one looks at economic impacts, is that effectively people who engage in caregiving but are getting increasingly better educated are effectively becoming more and more expensive. Their time out of labor force is becoming more expensive. Their opportunity cost is getting higher and higher because they are better educated and they command higher salary on the market. So every hour that they spend not working is worth much more than for those with less than college education. And we've seen that since the number of older adults is growing, the number of people in the working contingent, the working ages 20 to 64, which would be the ages of their children, is not keeping pace. There is less selection on education in terms of who are the children providing care. In other words, in the past, you had situations where, if there was a family where there were 4 kids, then the one kid that didn't go to college maybe would be the one that would stay and take care of mom or dad. But these days, there's only 1 or 2 kids. And the chances are that 1 or 2 kids are getting college education. And so taking any of them from the labor market becomes very disruptive and has very negative impact in terms of the incomes that they can make. So that's an additional important factor. So it's not everything is driven purely by demographics, but also by these population compositional factors. And then obviously, when one is not working, one is not paying taxes. And so there's going to be lost federal income taxes for the government. They're quite small right now, but they're going to grow in value in the future. Beyond this, and this is something that I simply didn't have data to look at, are other secondary costs of unpaid caregiving and lower labor force participation for the government. Those include things such as higher spending on health, higher spending on social programs. And those would definitely increase as people are out of labor force, they have lower incomes, they also are burned out, they have to deal with all the burdens that come with taking care of their parents, and that negatively impacts their own health. So they have fewer resources, need more money, more likely to qualify for social programs. Their health is worse, therefore they are more likely also to need government health programs. And so those are additional impacts that are not even captured here. So this brings us to the discussion. So we saw that because of the higher risk of Alzheimer's disease and higher reliance on family caregiving, the economic impacts are disproportionately high for African American and Latino population. Now, essentially, when we combine all these numbers, these various numbers that we've seen, we can see how dementia will affect economic well-being of African Americans and Latinos in particular over the next 4 decades, where it's going to increase the economic impact from about 100 billion in 2020 to 1.4 trillion in 2060. And that's going to outpace by quite substantially the growth for non-Latino white population, which currently the costs, the economic impacts of dementia on white population are estimated to be at about $170 billion. and that is going to grow to less than 1 trillion over the same time period. And that's disregarding the cost of paid care. Once you account for cost of paid care, then the total cost for African American and Latinos goes up to about 1.6 to 1.7 trillion, and for non-Latino whites to about 1.2, 1.3 trillion. So these numbers are staggering. And so even if you would combine these two numbers, so it's about total of 3 trillion, and you would go through that mental math that I told you in the beginning to come up with real numbers, so the numbers that would be equivalent to using current 2020 dollars, that number would still be around $1 trillion. $1 trillion. Okay, which is sizable by any measure. The growth of older Latino population is the primary source of the fast increase in the economic impact of dementia on non-white populations. But as I said, there are other elements, in particular educational attainment, that are also important and that partly drive the growth in economic impacts above and beyond demographics alone. And the adverse impact on African Americans and Latinos is going to rise substantially in the coming decades. And as is the case now, it's going to remain the case in the future that most of these additional costs are going to be falling on partly older adults themselves, but arguably even more so on their families. So there is definitely scope in the context of health and economic equity for policy and clinical interventions that would lessen the burden of dementia for older Americans. Now, because working age family caregivers are especially negatively impacted, these increased policy efforts are especially needed to lessen caregiver burden and to facilitate their dual roles as caregivers and workers. Now, there may be a whole range of different policies that would be needed. And some of these examples include enhancements of programs to support employed caregivers, and also to further expand and make more flexible paid family leave. There has been traditionally, paid family leave has been used primarily to support young parents as they are welcoming their new baby in the family. But paid family leave programs have been expanding over the time also to include stronger emphasis on taking care of other family members and older adults in particular. However, the data show that the utilization of paid family leave for caregiving of older adults lags far behind the utilization of paid family leave for newborns. Additionally, expansion of community-based programs that support and compensate family members for providing care, and there have been some demonstrations in this respect. Enhancing respite programs, absolutely important, and increasing availability of in-home professional care and improving coordination with family care provision. So while these interventions are important and should be developed and refined. Another important aspect is that both researchers and policymakers should focus on including African American and Latino families that live with dementia in the clinical trials and demonstration projects, so to ensure that interventions are indeed effective for all communities. So with that, I'll conclude this presentation, and I am really looking forward to discussion.
That was some sobering data, that was for sure. Wow. Thank you so much for providing all of this information. We did have a comment. Brenda mentioned that people out of the labor force will also not be contributing to their own Social Security savings accounts.
Yes.
I don't know if anyone's looked at the implications of that, but
yes, that is absolutely true, and that is one of the things where there has been some, people have had this idea that caregiving should count at least in terms of having your Social Security benefits, right? And so there have been those proposals over the years, but nothing has been implemented as of yet. There are examples in other countries. Not so much, I would say, in terms of caregiving for older adults, but especially caregiving for young children. There are many European countries that that are providing paid time off for parents for the first year, in some cases even longer, and are actually crediting parents for during that time. So it may not be paid at 100% level of the earnings that were while they were working prior to the birth of the child, but the Social Security payments or the retirement payments continue during that period of time, and that is definitely something that also my colleagues from the Urban Institute, where I used to work, where I'm still affiliated, one of the ideas that they were advocating for.
Anne also asked if there's any best guess about the expenses of caring for a family member with ADRD and how it might deplete the next generation's inheritance.
Oh, well, yeah. I mean, so it is. This is not unique to ADRD per se. It's even broader question of long-term care in the United States, and the fact that Medicaid is the primary payer. But in order to qualify for it, effectively one needs to impoverish oneself. And so there are some exemptions as it relates to the primary residence and some minimum income exemptions. But honestly, it is very, it really, for the lack of better word, messes up with people's plans in terms of the inheritance and passing on wealth to the next generation, because effectively at some point people have to dig into their wealth and spend it down before Medicaid kicks in. So that really negatively affects many people.
And Diane was wondering if you could give an example of preventing these economic impacts with perhaps some environmental strategies. I think you'd mentioned something about that.
Yeah, so I mean partly it's what we consider environment here, and so the way I conceptualize here retirement is how researchers in this area tend to think about it. So we think about it as exposome, and exposome tends to be basically environment writ large, anything that is outside of our body and genetics. And so this really includes, it's almost like it's social determinants of health, but then it's also all these other environmental elements. And so there is a lot there that can and should be done. I mean, we are talking about, for example, importance of education. Education is one of the most consistently protective factors when it comes to dementia. And in fact, even though the number of people with dementia is growing quite fast, the prevalence of dementia at the population level has sort of tapered off and even went down. So at any given age, the risk of dementia is going slightly down, but there's just more and more older people. And so the sheer number of older people overwhelms what is on the flip side a positive trend of having a lower prevalence at any given age. But one of the main reasons why, or we suspect why, there's that a lower prevalence of dementia at any given age is because of better educational attainment, because every successive generation is getting better and better educated on average. And so education is definitely important. There are also many studies that are looking into neighborhoods, the impact of neighborhoods, built environment, the ability for people to walk, to exercise, then food environment, the accessibility of food, availability, the quality of food, whether you live in food deserts or have access. And even if you technically don't live in a food desert, what kind of quality of food is available, whether it's healthy protein, vegetables and fruits, or it's corner stores with highly processed foods that is available in the neighborhood. So all these factors have been found. And then speaking more strictly or about environment, there's an element of air pollution and all these things that have also been linked with Alzheimer's.
And the other thing I was thinking was folks who develop dementia may be very distant from family members, and so there's a need for people to move, to connect, mm-hmm. and provide that caregiving. Have you seen data on that at all?
There is not much data, but I'm actually working with my colleagues on an NIH grant that looks specifically at moving and how family members move in response to onset of a health need, mm-hmm. And then distinguishing between dementia and other conditions. But there's definitely an element of disruption and that comes with the onset of a disease, because we see that there's a much higher likelihood of people moving together. Now we've been actually trying to explore whether people are going to be also more likely to move at some close distance, for example, to live within 10 miles. So if they live far away, are they going to come to live nearby? And then also who's going to move? Because the moves can be from both sides, right? So most moves are actually happen from children to parents. So mostly it's children moving in with parents, but it's not given. It partly depends on the context. If you have children that have families of their own and children of their own, and they're already well established wherever they are, then oftentimes you'll have actually parents moving with children as opposed to children moving with parents. But on average, it's still more likely the case for children to move where parents live. And there is some evidence that the characteristics of the place where parent lives and where child lives as well, that they do matter in terms of who's going to move. Because, uprooting your family from one place and moving to another place has implications. So it really matters what is the quality of local labor market and what are the opportunities for children to work, because many of them don't want to stop working or simply cannot stop working. So it really matters what kind of opportunities they have. If they're moving with parents, then rents don't really matter. But if they're not moving with parents, then local rents do matter a lot. And another is obviously the quality of schools and other things for those who have children of their own. And then, level of crime, all these elements come into play. So there are all these like push and pull factors, and it is a very complex process. It's life, right? So it's a very complex process where there's also intra-family negotiation in terms of who's going to move, especially if there are multiple siblings. And then even when that is decided, then it's whether the parent moves with child or child with parent, and all these considerations. And it's not always just a one-way street, because we are not talking exclusively about parents who are fully incapacitated and unable to do anything. So sometimes there are these advantages of parents and children moving together, where even though they moved because of the onset of parents' health decline, there is still benefit that children get because now grandparents are around and they can help at least a little bit with grandchildren. And so you will see when people are reporting on who benefits from the move, parent or the child or both, you will see often that people give answer that it's both. And so it's a complex picture, but it's absolutely something that is an important topic.
Well, and then Richard brings up the point that missing from this discussion is that many people are not having children, so who cares for them?
Oh yeah, and I love these questions because they all speak to aspects of the research that I have. So just a few years ago, I actually had a paper published on living alone, and it was actually comparing, the patterns of living alone cross-nationally, and looking at the United States and European countries, and so what is interesting when it comes to living alone is that oftentimes there's this notion these days that living alone is inherently bad. Now, it isn't. But there is a clear bifurcation in the population of those who live alone. There are people who live alone because they chose to do so, and they can do it. They are in good health, they have enough resources, and they just like their lifestyle. And there is absolutely no problem with that. And you have more than half of those who live alone are actually fall in that category. There's a substantial minority of people who live alone because they have no alternative. And so these are people who are really then, in a precarious position where they are a health emergency away from being in a really desperate position. And so what is important is really identifying those that don't necessarily want to live alone, but may have, had their spouse die, they don't have children, or their children live far away, and it's not practical for them to move and to double up. And they are in a pretty challenging position. And you can see when you do cross-national research that socioeconomic differences systematically vary by likelihood of who lives alone in more generous welfare states versus less generous welfare states. So that's another aspect. In other words, there are more of those people who are in a potentially difficult position in less generous welfare states, as you would imagine, than in more generous welfare states.
And there was some research that I was looking at this week that was differentiating living alone versus being lonely. And maybe that gets at your statement about some people choose to live alone, but they're not
Yes.
lonely.
Yes. That's absolutely correct. I think there was even at some point it was maybe British government that established not necessarily the ministry, but like an office of loneliness,
Yes.
because there is this awareness, growing awareness that loneliness is becoming an epidemic. And that
And linked
that
to dementia was the
yes,
implication.
yeah, absolutely linked to dementia, and obviously linked more broadly to also mental health,
Mm-hmm.
and it's not only unique to older adults. I mean, if we broaden the discussion, there's loneliness growing across the age spectrum, but it particularly affects older adults, especially those once the mobility declines, then people are less able to engage with their friends and social networks, and that really then often triggers. So people who may be alone, living alone, they may not have their spouse anymore. Kids have moved out, but they were still very much engaged. They had their circle of friends, they had activities, but once the mobility starts declining, and the ability of people to move freely in the neighborhood and beyond, that's when you start seeing this health decline being followed by emergence of loneliness.
And Mary posed the question, which will sort of get at my goal of having a bit of interprofessional interaction. Does anybody know if the old home share for seniors still exists in any form? I believe it was run by Pilgrim Housing way back in the 80s. Does anybody know anything about that? And then Anne mentioned that she's part of a virtual village of about 150 elders who agree to look out for each other. There are villages in various communities, quite a few, I think, in the Pacific Northwest. And she said they have many ways of having fun, but also support each other in many ways when lives unravel. This model is growing fast in many urban and rural areas.
Yeah. And I mean, we have something that people refer to as naturally occurring retirement communities.
Mm-hmm.
And so that's been a model that has proven to have a number of benefits for older adults and their health maintenance. And because those are communities where services are really tailored for the needs of the population. And yeah, so those are definitely some good examples. And then partly it's also one can say to some extent that some of these efforts have been helped with the global healthy aging initiative. And so many cities around the world, for example, have made pledges around healthy aging goals, and those are linked, with adjusting the public transportation system and number of other things like that to respond to the needs of aging population.
Katie had mentioned something about Old Friends Club, and I'm not familiar with that, so I asked her, but if anybody else knows of other kinds of groups like that, please feel free to share that information. I recall I went to visit some senior care facilities and models in China about 5 to 6 years ago. And one of the dilemmas that they were discussing was the fact that, they had few children. And so they were trying to set up systems to support older adults. And then it was within a year or so that they changed that one child law in China to
Yeah.
support more family support. Oh, Katie says another fast growing model is adult day programs to provide caregivers with respite. And I was going to ask if we still have folks from any of the AAAs, the area agencies on aging, because I think you have programs and experience with identifying structures and systems to support both caregivers and respite programs, as well as adult day programs. So any other models that you can think of? And thanks for the link, Katie.
Yeah, and I would say that's one thing that is absolutely, important. This element of trying to coordinate between what the public health supports can provide, and what the market can provide with what the family provides, and that's one of the areas, one of the few areas where we can do something to control these growing costs, because it is very hard. I mean, going back to that example of China, there's that demographic situation doesn't change overnight. The demographic situation changes over many decades. It's like a big ocean liner where, once you turn that rudder, it takes a long time for the ship to turn. And there is actually no guarantee or anything that says that in any foreseeable future we will have any relief in terms of population aging trends. If anything, the fertility rates in the US have been going down. They have been going in the wrong direction. And I mean, as a parent of two little girls, I can think of at least few economic reasons why it is challenging to have small kids, right? And so in that regard, the government doesn't help much, right? And so yeah, that's something that we need to live with as a fact, and that further emphasizes the importance of being more mindful of and efficient with the limited resources that we do have at our disposal.
And May mentioned that she works for Full Life Care in Health Home, and that they have an incredible adult day health program, and that's in the Puget Sound region. I don't know if there are other programs that folks in other areas want to point out. Snohomish and King County. Yes, thanks, May.
I would just like to say, I mean, I would definitely like to connect with all those that are working in this space, because I'm really one of the ways how I'm hoping to further expand the line of research on caregiving that I have, is really to go beyond just the secondary data analysis and to connect it with primary data collection, with the experiences of people who are working on the ground, successful models, etc. Because that mixed or multiple method research is really something that, at least until a couple of months ago, is something that both NIH and a number of other federal agencies were very much interested in, and where they largely saw the future of science. So marrying the hard data and the growing large data sets that are available with ways to implement it and bring it closer to implementing these ideas on the ground.
Well, and I think that moving forward, having that data is going to be so important for policy that then supports developing more programs and services. And that's something that our AAAs and some of our other agencies are really working hard to affect. So contact Dr. Mudrazija
Please feel
for
free.
the data as well as to contribute to that data. And everyone, thank you so much for joining us today. We will see you next week, which is the last week of this series. And then the spring series will be starting up. And have a nice weekend. And don't forget to set your clocks forward.
Thank you all.
Thanks very much.